Thank you again, Dorothy, and everybody welcome. I'm sure some of you, for where you are, it is good evening. For some of us, it's still a little bit morning, good afternoon. Welcome to this series of webinars that have been put together by the ARCA organization. That is, we are trying to bridge the gap that we know clearly is there between in healthcare in Africa. And I've listened to a few webinars, and I have heard in the background that there is a lot of things happening in the background, and necessary deaths because of lack of education. So we are trying to do push on education on some of the things that we can help either at the bedside as caregivers for those people who are caregivers, also in the home for the providers. The nurses also included in this because they are doing a lot of this work. So I'm going to start sharing my slides here, and our topic today is, and let me know how it looks on your side so that we can. So I am sharing. My topic today is about tracheostomies, but thank you again to ARCA for this time to share this. I am going to start with a disclaimer and say that the topic today is only for educational purposes only. So we want it to be disseminated as education. It may not be in any way be taken as medical advice. I, as the presenter, I do not have any commercial relationship with any manufacturers of products that I mentioned in my topics today, my main topics today. And also, I want to look at, as we discuss this topic today, I want to look at.
Oh, can you put it in a presentation mode?
Yes, I am. So I want to look at some two studies that I looked at and I was reading through. And these studies came from Africa. One study was done at Kenyatta National Hospital. And the title of this study was The Risk Factors of Early Complications of Tracheostomies. That is at the beginning of the tracheostomy during the procedure. Early complications will usually happen between day 1 and day 10. And now the other study that I looked at was clinical indications and late complications among adult patients done at a medical center in Tanzania. Our learning objectives for today for all the practitioners that are listening and watching will be one, to recognize early complications such as bleeding. That is a big one. Also to describe late complications, including fistulas, stenosis, granulomas, obstructions. Demonstrate interventions for emergency situations. Apply preventative strategies and routine care using protocols that work. Educate patients and caregivers on signs of complications. I'm going to start with a question to all of us that are attending today. The question is, where can you gauge your knowledge of tracheostomies? Are you, number one, are you advanced? Do you have some knowledge? Is your knowledge at a minimum, or you don't have any information about tracheostomies? Please post your answer in the chat or the Q&A so that at least we can gauge and see where we are with this procedure in terms of what people know and what kind of education that we should prepare in future. So this is going to give us a headway. Start with a history, a little bit of a history. The oldest and the simplest procedure is the tracheostomy procedure. And it was rarely performed until the beginning of 19th century, and that is less than 20 years ago. Surprisingly, it was use was limited. mention that I found of the first procedure was in writings of two Greek physicians, Galen in 2nd century, who accredited Asclepiades with being the originator of the operation, and also Aretas in the 2nd century. I did not find records of success, but the interesting information that I found about this is that they did the procedure, the surgical procedure, while the patient was sitting in a chair, and they would hyperextend the neck. They would try to reach and create a stoma so that they can place a tracheostomy. I have not seen pictures of what kind of tubes they used. Uh, um, that is yet to be found, but they somehow tried to create some sort of an airway. Now, many of these patients did not survive because the procedure was really in the early stages. This is probably trial and error. So there has been great advances, as we can see today, for those of us who are in the clinical area can see all the advances, and we're going to talk about those ones later. So the reasoning for tracheostomy is the reasons why patients get tracheostomies. There are many reasons, and as respiratory therapists, we know patients would be on a ventilator prolonged times. And what happens is that at day 20, you are thinking about removing that oral airway, which is the ET tube, and the surgical team is thinking about placing a tracheostomy because you cannot have that ET tube in the oral airway. It's gonna destroy some of the organs, your tongue, you got your vocal cords, because of that plastic causing pressure on the tissues. We also want to bypass an obstructed upper airway. Maybe you're not able to access the upper airway immediately and it's obstructed. You would do an emergency tracheostomy procedure, park trach, as it is referred to. Some patients have a lot of secretions from the airway. They are not able to clear that, and sometimes it is necessary for them to have tracheostomy. Also, you want to deliver oxygen to the lungs more easily and safely. Maybe you've tried all the other adjuncts. You have tried the nasal cannula, you've tried high flow oxygen, and this patient is not doing well on those, and you want another safer mode of delivering oxygen for hypoxic patients. They get a tracheostomy. During trauma, patients will come and they will be trached in the field. I'm thinking about a burn patient who has been rescued from a burning building or car, and they have the upper airway swelling, and the emergency crew is not able to place an oral airway, an ET tube. What would they do? They would crack and place a trach in the airways to be able to ventilate. Traumatic brain injury patients also, they are not able to clear their own secretions, breathe on their own because of the injuries that they may have in the brain. Spinal cord injury, same thing. They will not be able to breathe on their own because sometimes what happens to the nerves in spinal cord injury, the diaphragm gets innervated and it does not move as it's supposed to. So they need some assistance. This is some of the results or the numbers that I pulled from the studies. And I was looking at some of the complications from this study. As you can see on the pie chart on the left, number one there is decannulation. And of course, decannulation is the accidental removal of the tracheostomy, head injury, cardiac complications, and pneumonia. During the operation, on the right side, I have a table of the complications that may happen. hemorrhage, meaning they may bleed during the operation, decannulation accidentally, meaning in this case, decannulation means that they probably have placed the tube in the wrong place. It's possible to go through the trachea and to the esophagus. It's also possible to go through the stoma and to an area right between the trachea and the skin, right in there, false track, and place the airway falsely. You have injury to the structures, and tube also gets displaced. Now, after the procedure, you also have 7 patients that died, 17 patients that had a pneumonia. Emphysema was 15 patients, decannulation, infection follow, and tube obstruction also follow. So overall, the complications rate were found to be 23%, and early post-operative complications were found to be 42%. At 42%, we are saying that we have 4 out of every 10 patients having complications. In Tanzania, we have a table here with the gender of people who had the procedure, the gender of the female to male population. Male population was higher. They have reasoning why they did have the tracheostomy procedures. The table on the right side shows that there are also complications, pneumonias, tube blockage in this table, tube blockage, apart from not having any complications at 44, tube blockage is number 1. Tube blockage is number 1. Now, tube blockage can be prevented. It is probably caused by dried blood. It is also could be caused by dried secretions. It could be caused by the tube getting malpositioned. Maybe patient going, a long time not being checked to make sure you can suction. These are things that we can prevent. So the airway is compromised by, like I said, dried secretions, blood clots, a displaced or overinflated cough. Because when you do overinflate a cough, meaning the cough around the trach gets overinflated and the position of the tube is not right in the center of the airway, that could cause a blockage. And that is what we're talking about, your tracheal wall, if the tracheostomy tube is malpositioned. I have a picture here, does not look really good. And this is a picture of a blocked tube. On the left side, as you see, you can see that right in that tube is some dried secretions. The other thing I see around this trachea on the flange right here, as you can see, is that there has not been any cleaning around that area. Also looks like dried blood. I do not see any active bleeding. So there is some work there to be done to maintain that airway. On the right side, this is a blocked tube. You would not be able to see this if this tube was in a patient. You would be having probably a symptom of where a patient is coughing nonstop, or you not able to pass a suction catheter to be able to suction. Patient is not able to breathe because there's no air that can go through that tube the way it is. So those are some of the things that you can see with a blocked tube. So here we have Christopher Reeves. He was a Superman actor, and he did act in a 1978 film with the same name. And he actually had a spinal cord injury. He eventually got a trach. He was on a ventilator because when he broke his spinal cord, he destroyed his diaphragm and was not able to breathe. So that is one of the famous patients that I can talk about that was I found that had a tracheostomy. He did last well with a trach and on a ventilator. He lasted for seven years and died of a pneumonia infection. I have a picture here of the structure of the trachea. Now, I looked back to some of the things that I have seen with caregivers, clinicians at the bedside, respiratory therapists, including also nurses. People are not aware of how the airway works or how the trach is placed in the airway. And so when they are manipulating the tracheostomy, they are not, they don't know what they are dealing with. We've seen that a lot, and that sometimes does end up causing problems. So I do have a picture here of the cartilage that is that holds the airway together, and that is from the top, from the hyoid bone all the way down to the bifurcation of the airway. As you can see, that is the area where is most important, the area where the trach sits in there, right in there. If you count ring 1, 2, and 3, the trach during the procedure will go in right there and will go all the way to up to where right above the carina. On this picture, when you think about bleeding and tracheostomies, if you look at this picture, I do have the trachea on the left side right here. We are seeing the esophagus, and this is going to make sense later on in this discussion. And you see the muscle wall right here, but you see all these vessels here that are right next to the trachea and esophagus. When you have the trach in the airway, you're also dealing with vessels that are right there. So there is a very close relationship between the airway, the esophagus, and the blood supply that is right around the trachea. So again, I'm discussing this because so that we can have a picture of what it looks like around the trachea, because it is important for you to have the big picture so that you know what you're dealing with. And if you start having a patient that is bleeding, you start having an idea of what may be happening. I have another picture here from the front. Now I have the arteries right around the area where the trach goes. Blood vessels around the trachea. Again, you can see the major arteries. You can see the veins. If you where we counted 1, 2, 3, the trach will go right there. As you can see, my pointer. Those are small veins. You're probably able to go. The surgeon is able probably to go through there and stop the bleeding. But what they want is not to touch the innominated veins here and the arteries right here. Those are major vessels. So if you find a patient with long-term trach, the trach will be right in here, but all around there will be some very important vessels of blood. Now, what happens if over the course of maybe somebody has a trach for 7 to 10 years? What is likely to happen to these vessels? In some instances, there's gradual erosion. So gradual erosion into these vessels and these vessels normally leads to death. It's very hard to stop this bleeding in a case where the tracheostomy gradually erodes into these vessels, because these are main suppliers of blood into the brain. As you can see, this is the left and the right, the carotid arteries. So it is very important to know what we are dealing with when we are taking care of it, when we're suctioning, when we are manipulating it, when we are changing it, be aware of all the vessels that are blood vessels that are around that area. It's very important. That's why I included that slide. On this slide, the surgical team will do one of a few things. They would place that trach using an open tracheostomy procedure. This is where they actually cut and they count the rings, and they mark the area that they're going to put the trach. As you can see right there, they're aware of the vessels. If bleeding starts immediately, it can be stopped because it's right there, it's open. And that is one way of placing the tracheostomy. The other way of placing a tracheostomy is the percutaneous dilation of tracheostomy. It's not at all bloody. It uses just a needle with a syringe, and they go in, find the airway, and they would use a bronchoscopy to guide, to visualize in the airway to see where that needle is. Once they know they're in the airway, then all they do is dilate that area where the needle was right there. They'll start the dilational process, make that stoma bigger so that they can put in the trach. These are some of the dilator tools that they can use. The left one is the blue rhino. The right one is the white rhino. These are just names that they use for sales. They do exactly the same thing. You have right there, you have your syringe, and they introduce a needle right there. You have your wire, guided wire. You have your rhino, and you have your trach. Straightforward procedure. And of course, this is done by qualified surgeons that are trained in this procedure. This is a new procedure for tracheostomies that I have seen. I have not witnessed this one. It looks like they have something like a screw goes in, and again, what they do is they use this screw after making the incision to dilate and then put in the tracheostomy. So these are some of the techniques that are being used. I wanted to show you first to start kind of with the anatomy and physiology so we understand what is going on around the neck where the trach goes in. And then over here, we are looking at the overview of the ways that they use to put in the tracheostomy. Now, some of these procedures can be done at the bedside. If you have the necessary equipment, the necessary staff present, the patient is stable medically, doesn't need to be, sedated or paralyzed. Some of these procedures can be done at the bedside. At the discretion of the provider, they can go to the OR and perform that. So wherever they choose is where that happens. Over here, I have complication of tracheostomies. Again, we have immediate complications. Those will happen right there while the team is doing the procedure. We also have the early complications. This may happen at day 1 to day 10. Late complications happens when patients have been dependent on tracheostomies. So tracheostenosis is a big problem. Is where the airway kind of contracts, gets smaller around the tube. Granulation tissue grows around the airway. When you have that plastic in the airway, the body reacts sometimes by just growing some tissue around the trach, and that can cause problems. The other thing you have is tracheomalacia, collapse of the tissue just in the airway. Because you have an artificial airway, aspiration it happens. Pneumonia will happen when you aspirate. We also have fistulas between the trachea in the esophagus, accidental recannulation, and also the dysphagia, which is issues with swallowing. All these are complications that do happen later in life. The rest of them happen early and immediately. Let's go. I wanted to talk about tracheostomies because as the procedure happens and as we have the complications, it is important when the procedure is done, the right size of trach is used for the right patient. What I mean is that if you have a smaller woman, probably 100 pounds, with a smaller neck, you're not going to put in the same size of tracheostomy that you'd put on a 200-pound gentleman. So it is very important to choose the right type of tracheostomy. There are so many different types of tracheostomies out there. There are so many companies making this trach. So it is important for the surgeon, the ENT, the pulmonologist also to actually do some measurements. Make sure that they know what tube they're going to use on that specific patient. Right here, this is just a shyly regular trach. It might be an 8 cuffed trach. As you can see on the trachs, you have numbers that are on the trachs, and a lot of times people look at them and are wondering, what do these numbers mean? So at the top is of this trach, you can see that's the actual size. Some tracheostomies have inner cannulas. That would be the inner cannula, inner diameter, and then outer diameter of the tracheostomy. Those are what those numbers mean when you look at them. If you look at this here, we're going to look at the pilot balloon here, the trach, and the cuff right there. Let's look at another type of a tracheostomy, and this is called a Bavona adjustable tracheostomy. If you look at it right here, it has a clip right here that you can open, release, and the shaft inside here can move up and down. The shaft right here can move up and down, meaning you can adjust the size of this trach. A lot of these trachs will go as deep as 120 millimeters or even 140. You can also order custom-made trachs, and this is dependent on what kind of a patient you are dealing with. If you have an obese patient with a really big neck and a carina that is really deep, then you're going to have to do some measurements from the carina, do some measurements, and order a custom trach. If you're having to bypass an obstruction in the trachea, you also use this kind of a tracheostomy. Right here, we also have fenestrated. Fenestrated tube allows some people who are sometimes on long-term tracheostomy to talk. When it's deflated, the air moves up and goes to the vocal cords, and they are able to talk. That's a fenestrated tube that I have not seen a lot of use of these ones because there are so many different sizes of trachs nowadays. You can just change a trach from probably a 7 to a 5 and use a PMV valve for the patient to speak. So that is a fenestrated tube. I'm going to talk about proximal and distal tubes because they're important to know what kind of a tracheostomy a patient has. A proximal tube versus distal tube. Will be clearly marked on the trach. As you can see right here, A is proximal. Right here, it is close, but it's right here. It is for a thick neck patient. A right there, thick neck patient. Distal. The cuff is distal, but here, as you can see, the difference is for a thin necked patient. If you try to place this tracheostomy into this patient, you would have problems. First of all, they will not even tolerate it. You will not be able to ventilate. You have a lot of problems with that trach. So it is good to also choose the right kind of tube for the right kind of patient. So it is important to always keep that at the back of your mind. Again, here we have the Shiley XLT tracheostomy tube clearly marked. As I say, the Shiley XLT Proximo is marked right there. The other thing you see here, this is also another kind of tracheostomy. It's cuffless. It has no cuff. You probably don't need the cuff there to manage this airway. They probably are not going back on a ventilator. They are clearing their own secretions, so you are seeing clearly that. Also, the inner diameter is the same as the trach tube size over here. The outer diameter and the length of the tube. This has a length of 100 millimeters. Cool thing about this tracheostomy, it has an inner cannula that is you just click it, pull it out, and replace with a new one. It is important for those inner cannulas to be changed regularly, because if they are not changed, then you could have tracheal blockage. These trachs are very easy to manage. So it's just pulling the inner and unlocking it, pulling it out, and putting in a new one in there. So as I alluded to, how are we able to avoid these complications when we have them? We know the correct size to be used on the onset of the surgery. Proper trach care by trained professionals to help with suctioning. So it's important to have trained professionals. And I know this is one of the main top agenda by ACA to have in Africa, to have the proper professionals to take care of some of these patients. These are people who take care of, suctioning, hydration, secretion, thinning, either by medications, by heated moisture, routine cleaning. Inner cannula care also is important. Speaking valve and cap use. So sometimes when you place a speaking valve, which I'll show later, or cap the tracheostomy, patient is able to breathe maybe normal, even though they have a plastic in their neck. And when they breathe that way, they're able to draw moisture from the air into the, so they don't drive their secretions. If possible, have some heated or humidified air or oxygen. Proper emergency supplies at the bedside are important. Have a spare trach, a smaller trach size. Also have the same size. Teach proper techniques for trach replacements. So right here, I got some pictures which show from bronchoscopies what are some of the complications that can happen for patients that have had tracheostomy for a very long time. I said some patients have had trachs for more than 10 years. What happens to the airway? As you can see, that right there does not show any normal airway. Right here, as I talked earlier, you have stenosis. The airway has narrowed right there. In this case, if you did try to decannulate, in other words, if let's say the patient never needed that trach and you tried to remove it, that patient will not do well, because the airway would be blocked by that extra tissue. And this is kind of like what happens is that the airway kind of constricts around the trach. Over here, you can see also some tracheal Malaysia, floppy airway. Small stenosis here, really small size, kind of pinhole area left to move air. That will be difficult for breathing. Also here, you can also see some floppy airway, some Malaysia too, and also this would be a problem. The ENTs, ear, nose, and throat providers will try to fix this by a laser procedure, try to cut away that tissue, extra tissue in the airway. The other thing they try to do is pulmonary intervention will try and place a stent in there. They have not been very successful. Sometimes they prolong a life for some of the patients. The only way you can clearly bypass some of these floppy airways is by having one of those adjustable tracheostomies, which you can use to that tracheostomy right there. I'm going back. Can be used to bypass those floppy areas and the stenosis. That's why you need that adjustable trach. So what you do, you just place it in and push it past that area that is completely collapsed. Let's go back here. So that is what would happen to in the later stages of having a tracheostomy. The picture here kind of shows where I'm going to point right there. That's where the stoma is. This is where the calf level of the tracheostomy sits. And due to the inflation and deflation so many times of the tracheostomy, this happens to the airway. It constricts on the inside. And this is the distal end of the tube. And what happens here, this can cause ulcers in the airway between here and the beginning of the trach. You can have the tracheal esophagus fistula, trachea innominate fistula, meaning the fistula is from the trach into the innominate artery, where the survival rate is really low. Stenosis, Malaysia, granuloma, all happen around the calf level. So the adjustable airway that I showed would go in here and you'd push it through the stenosis right here, and it will go stop right there. And therefore, in this case, you're able to ventilate this patient. Again, some lesions can grow in the airway too. Look at those granulomas. Again, you're trying to, pulmonary intervention is trying to go in there with a laser and a bronchoscopy to try and cut that out. This is caused by normally associated with presence of chronic infection in the airway. This will happen when you have a trach because you are aspirating. Some people are having tracheostomies, they're trying to eat, they aspirate, and this might happen. Tracheomalacia, another picture here showing the Malaysia, what happens here. Right there, I'm going to point where there's a round circle. As you can see, the softening of the cartilaginous rings, which causes collapse of the trachea. So all these pictures are showing what happens to the airway when they've had a trach for a long time. Is your patient appropriate for a speaking valve? Is your patient appropriate for the cap? I don't have a picture of the cap, but these are some of the questions that you can ask yourself when a patient has had a trach for a long time. You can start with trials and see whether they're able to tolerate the calf deflation and also the PMV. These are two types made by two different companies. And what the speaking valve helps the patient to do is to be able to speak. It has a valve right in there. If you put it on the tracheostomy, when they try to exhale, the air is blocked by this valve. The air goes up to the vocal cords and they can vocalize. The one thing they have to do is they have to be able to tolerate that on the trach. The other thing they can do is they're able to manage their secretions. They can cough up the secretions just like normally would do. They have to be medically stable to do this. If they have a really severe upper way obstruction, high aspiration risk, excessive secretions, inability to tolerate calf deflation, and they are really severely or medically fragile, you cannot do any of this. But this will be important to help in managing secretion, also helping clear those secretions so that they don't harden to cause obstruction. You can also try to use some humidity setup. The bottle that's set up with some humidity to the trach to thin those secretions so that they do not block the airway. Over here, you have emergency tracheostomy management. This is a work that was put together by the UK National Tracheostomy Safety Project to standardize care for healthcare providers, including people who take care of patients with tracheostomies, to find a standard way. I think it is important to have a standard way of taking care of emergencies when they do happen. What emergencies can you have with a tracheostomy? As we had discussed earlier, blockage. That is an emergency because you can't move air when it's blocked. Bleeding, trach displacement is an emergency. Um, so this is a way to take care of this patient. And of course, it starts with calling, if the patient is breathing, you don't have to call the resuscitation team, the RRT team. You start doing the emergency actions that you have been trained in that can help you secure the airway. So this can be a really important thing to go back to look at. For those of you who are thinking of things you can do for your hospitals, even for your departments, this would be a very important way to place to start to put some stuff together that can help in case of emergencies. From the numbers that we looked at, uh, tracheal blockage, as I began by saying that tracheal blockage can be prevented. And you can fix that if it's found in good time by changing that trach and removing the, whatever is obstructing that airway. So that is the management that we can put in place for our hospitals. The other things that can be done at the beginning of the onset of the tracheostomy is you can put in place some protocols where you can have some specific things to be done at specific times. For example, change the trach at between day 7 to day 10, not anything before. And the reason for that, the stoma has not matured. And if that tube is pulled out, you could lose that stoma and not be able to put in an airway, another airway back in. So most surgeons will say 7 to 10 days, stoma is fine. You're able to pull that trach and replace it with another one. It is important to have, probably, it depends on the protocols you're using and how things work at your hospital. It is important probably to have the same team that put in that trach to change that trach because they know that patient. They can remember what kind of an air. They can go back to the notes and look and see what kind of an airway it was. Was it a difficult airway? Was it easy? If they change that trach at 7 to 10 days, then we can have other practitioners, the PAs, NPs, RTs, change that trach subsequently after that. That is what one of the protocols that we do use. The surgical team has to evaluate for risk and benefits for initial trach change at around day 7. Also, initial trach change, also other people do between 7 and 14 days. Determine what kind of a trach you want to put in there, what type and what size when you change it. And also, do not forget to document because you want the next person that is taking care of that patient to know exactly what was done, what kind of a trach is in there, was it difficult? So do not forget to document. Some of the precautions for a fresh trach are here. You have to do routine Q6 depending on the protocols and the policies and guidelines for your hospital. Every 6 hours, keep an eye on that airway, make sure it's good. You can put in posters above the head of the bed for the patient. Do not manipulate the trach without discussing with the provider. Some people will have an obturator. So an obturator is a guide that helps you replace that trach back in the head of the bed. So if for example, it is come out and you're having a hard time putting in, use the obturator, goes in the trach, and you're able to push it back in. And that is also for people who are trained in that procedure to be able to replace that. Cannot be done by anybody. Remember, the structures I discussed at the beginning, the structures and the blood vessels that are around the neck and or the stoma, when you are replacing this trach that has come out accidentally, you are still messing with those the blood vessels around there, and it's possible you could poke one of them and just start a bleed. For ENT patients, they have to be very specific. ENT patients noted that the ENT and the ENTs have to do the first trach change. In some instances, the ENT, the ear, nose, and throat doctor will be the only one who can change that trach anytime. It does not mean that they just change the first time. Any trach change and subsequent trach changes have to be performed by the ENT. And again, that is also depending on what your guidelines are. For major medical centers, what they can do to have interventions at the ready so that these tracheostomy patients can be taken care of safely is having standardized protocols. You can have teams work on some protocols and training programs. Multidisciplinary care, meaning that the SLP, the RN, the RT, the MD, all of them have a close collaboration in the hospital and having either daily or weekly meetings for these tracheostomy patients so that we can all be speaking the same language, taking care of this patient. Patient family involvement when patients are going to be discharged to go home. There is a lot of teaching that is important for this group of patients, for the family members, also for the patients that take care of themselves, so that they can better manage themselves at home. More data collections is needed so that we can figure out the areas of improvement and innovation. We need, especially in Africa, low-cost tracheostomy care kits and image-based educational materials. So some of these procedures are pretty expensive. The equipment you're using at the bedside for routine care can be expensive. So low-cost tracheostomy kits would be helpful, and also financial and systemic interventions so that caregivers can be able to provide this care. There's financial burdens related to tracheostomy care. Recently, we had a picture at a place where I was of a patient that came into the emergency room with a tracheostomy. And what happened was that he had had this tracheostomy for more than a year in the airway, more than a year. It had changed color. It was no longer a tracheostomy that they had in the neck. It was something else. And why do we think that it had not been changed routinely? Because routine trach change when funds are available is probably every 30 days, maybe they couldn't afford to go to a doctor's office and get it changed. Maybe they didn't have insurance. So financial and systemic interventions are necessary so that we can be able to provide this care. So those are some of the interventions that can be done. And these are some of the resources that I looked at when I was putting together these slides. You can go back. A lot of them are for teaching. You can learn a lot out there. There's a lot on the web. So I hope this has been enlightening and educational presentation for those of you who are taking care of these patients. I am happy to have presented this, and I hope good things are going to come out of this. Thank you very much, Arka, and everybody else. I see 59 people, all participants here who have listened to this topic. Thank you, and have a good rest of the evening and rest of the day.
Thank you so much, Kennedy. for an awesome session in tracheostomy care. Yeah, so it is the Q&A segment, and I look forward to your questions and your thoughts on the topic that has been presented. I want to use this great opportunity to acknowledge the presence of some personalities in this webinar series. We have Dr. Audrey Forson, who is also one of the faculties for University of Ghana Respiratory Therapy Department. She's also a pulmonologist and one of the faculties that helps that respiratory therapy in Ghana. I also want to thank Wadie Williams, who is a former retired U.S. Army respiratory therapist. And then also from the American Association for Respiratory Care, I want to also acknowledge the presence of Madam Kelly Rose, as well as the governor for Argentina at the International Council for Respiratory Care, Olguin Gustavo. Thank you very much. We also have the Director for International Affairs at Zopec Medical, Madam Taya Lichty. We want to say thank you for participating. Kindly send your questions to the Q&A, and then we would answer your questions. Thank you. We have some few questions here, and coming from Melissa. It's a greetings from Midwest region of the United States. I am curious as to who generally does trach care in your hospital. Is it the RTs or the nurses? Or is it the hospital department?
I'm going to speak from my current experience. We do have a shared responsibility agreement for this kind of patients. So we do have the RTs take care of the trachs. We also have the nurses can do that, and they get trained on that. The RT department also has what we call respiratory care partners. These are students that are in school for RT, and they are employed to be able to do some of this care. There are limits as to what they can do because they are not yet licensed. They cannot have any invasive maneuvers on the trach, but they can do just general care around the trach. So the nurses, the RTs, and our amazing RTPs can give this kind of care.
Thank you very much. And I also want to add that in Ghana, our respiratory therapists also manage trach patients. Okay, so we have a question from Dr. Benga. He says, hello, I am in the West Coast and work at Cedar-Sinai Medical Center. At our hospital, nurses perform trach care, quick shift, but due to the increase of hire of new grade nurses, RTs have to educate nurses in performing trach care at times. So trach care at our hospital is a nursing responsibility. So it varies from hospital to hospital. Please keep your questions coming in.